So welcome everyone. My name is Gerry Rosberg. We're back with another in our ongoing series of webinars. We only have two of our three experts today. Melanie Burnett's not able to join us, so it's extra responsibility for Donna Lynne and Wafaa El-Sadr, but they've got a lot to talk about, especially in relation to the questions that many of you submitted in advance, and thanks for those. We calculated just a few minutes ago that it was February the 8th when we were last together. And at that point, we sensed that there would be no need for additional webinars, but there does seem to be enough happening, both with the pandemic and in terms of our policies, that we thought it was appropriate to get back together again and answer your questions. And that's what we're here to do today. The Q&A box is open, so please, if you have questions, submit them there. We won't try to answer them online. We'll try to take them up at the end, but you'll see that Wafaa's and Donna's presentations were carefully shaped to respond to the questions that we received in advance. So we're hoping to cover the topics that you identified as of most concern. So I think I've given a good minute or two for people to join, and I think Wafaa, we're ready to go to you. Please take it away.
Thank you very much, Gerry, and thank you all for joining us today. And I'm going to share my screen. Just give me a minute. Does it look okay, Gerry? Or somebody?
Looks good.
Looks good? Okay, thank you very much. Okay, so thank you. I'm going to do a brief presentation on multiplicity of topics today that I think would be of interest to our audience. So first of all, let me update you on the status of the pandemic overall. And I think, as you know, this past week, we really reached a very important milestone, which is that globally there have been more than 500 million cases of confirmed COVID-19 have been reported. And of course, we know that this is an underestimate because this confirmation requires having access to testing. And we know that in some parts of the world, of course, access to testing is quite limited. But importantly, I think you'll note here, in terms of where recent cases are being reported from, i.e. in the last 7 days, you'll see there's been a dramatic change. We always used to have most of the cases reported from Europe as well as from the Americas. What's interesting now is, as you will see, recent cases, or 50%, almost 50% of recent cases have been reported in Europe, here in the darkest maroon color, 40% in the Western Pacific region, while only 7% have been reported from the Americas. So this is, for people who are residing in the Americas, this is good news, is that it seems that at this point in time, at least the epidemic appears to be abating in our region. What about in the United States? And again, you'll note that this map of the United States, which I've shown many times before, is usually quite dark orange or maroon. And just by looking at the map, you can see that most parts of the country are here in yellow color, and this is the lowest rates, average daily cases per 100,000 population in the past week. And at this point in time, we're in the United States reporting about 30,000 or so new cases of COVID, confirmed cases of COVID-19 per day. I'll give you a little bit more details on the counting of cases and what it means and so on in the next slide. Now, what about New York City and the numbers of COVID-19 cases in New York City? And this figure shows the surges, the various surges of this pandemic over since the beginning of, since March of 2020. Of course, you need to ignore this initial surge in terms of numbers of cases, because we know that at that point in time, we did not have access to testing kits, and therefore the numbers of cases is way underestimated here. But nonetheless, you'll see over time the different surges we've experienced over time, including the Delta surge here. And this is the recent Omicron surge that we experienced in January and February of this year. And at the peak of the Omicron surge in New York City, there was reporting of about 43,000 new cases per day. You'll note here that when you see there was an abrupt increase in numbers of cases and abrupt decrease in numbers of cases with Omicron in the surge, but you'll note that we are experiencing this increase in numbers of cases here. You can see in the tail end of this figure here. Now, I need to remind everybody that we have to be cautious when we talk about numbers of cases, and that's for an important reason. And the reason is that obviously with the availability of self-testing, which is very important, and particularly home self-testing, many people who are getting tested at home, they don't report if they're positive, and they don't report if they're negative either. So in all likelihood, we do have an underestimation of the total numbers of COVID-19 cases overall. And as we move more into the pandemic, with the availability of antigen testing and self-testing, the metric of daily cases becomes much less reliable as a metric to follow overall. There are some parts of the world where there are systems for reporting of antigen testing, but here we don't have a consistent way of reporting antigen results. So this means that the daily numbers of cases is not a reliable metric. There are other ways of trying to get at the numbers of cases, and maybe we can talk about those during the question and answer period. However, at the same time, daily hospitalization also continue to be monitored, and you'll see here over time what's happened in the city. And here's the uptick in terms of hospitalizations per day. With the Omicron surge, reached about 1,000 hospitalizations per day at the peak. And then what we've experienced recently is a flat. There's not been an increase in numbers of hospitalizations due to COVID or with COVID. But I anticipate, since we are seeing an increase in numbers of cases, it would not be surprising that we see an uptick in numbers of hospitalizations. But clearly hospitalizations are a much more reliable metric as we move forward in terms of having our finger on the pulse in terms of what's happening with this pandemic. So I'm going to touch very quickly in terms of COVID-related alert metrics and thresholds, and this is the system established by the CDC, and the city has a very similar system. And essentially is dependent on a variety of different measures. One is the new numbers of cases per 100,000 people in the past 7 days, and essentially dichotomized by fewer than 200 per 100,000 or more than 200 per 100,000. And then another metric that's very important are new COVID-19 admissions, again, per 100,000. And another metric is the percent of inpatient beds that are filled with COVID-related patients. And you'll note in order to be in the low alert level, the community needs to be fewer than 200 cases per 100,000, and also less than 10 per 100,000 hospitalizations, and less than 10% of hospital beds being COVID related. I want to caution that, of course, you know from what I said already, is that this is not a very sensitive or reliable metric, the numbers of cases. So we have to be cautious as communities move from one level of alert to the next because of the limitations of this measure of the pandemic. So based on where we're at now, New York City is in green, and you'll see that this is because we have 167 cases per 100,000 in the last 7 days. So that's less than 200. We have 4.6 per 100,000 admissions in the last 7 days, so it's less than 10. And our hospital, our COVID-19 inpatient occupancy is about 2%, which is less than 10%. Now, there are recommendations. New York City has come up with recommendations on what to do as the city moves from different alert levels. And you see, for example, that the major difference between low or green and yellow is that in the low alert level, the recommendation is to consider wearing a face mask in indoor public settings where vaccine status is not known. And then in the yellow, it says wear a face mask in the same settings, as I mentioned, indoor public settings where vaccination is not known. But otherwise, the recommendations are very, very similar. How are we doing in terms of vaccines and boosters? And that's very critically important because I think vaccinations have a lot of benefit. They decrease the risk of infections, risk of severe illness, and which means that they have an impact on the numbers of cases, but they also have an impact on hospitalizations. So that also could be a reason why we have a flat hospitalization, is because our city, thankfully, has achieved a decent vaccine coverage. And you'll note here that of all the population living in New York City, New Yorkers, about 87% have received at least one dose of the COVID vaccine, and 78% are fully vaccinated. We have a long way to go in terms of booster doses, and unfortunately, we're only at 37%. And as you're aware, there are very solid data that tell us that booster doses are very important in terms of preventing severe illness, preventing infections, as well as also preventing particularly severe illness and hospitalizations. So I'm going to touch now on the Omicron subvariant, which is the BA.2, the one that's really circulating now widely. I want to remind you that whenever you hear about a new variant or a new subvariant, you should ask yourself these 4 questions. Is this variant or new subvariant more transmissible? That's question number 1. Number 2, does it cause more severe disease? Number 3, do vaccines that we have remain protective against this new subvariant? And number 4, are our treatments remain effective or not? So these are the 4 questions we need to answer whenever we hear of a new variant or subvariant having been identified. So obviously BA.2, the subvariant of Omicron, is now the dominant circulating variant globally. You'll see it from this map in pink, all the parts of the world, countries around the world, including the United States, where this variant has been detected in these various communities around the world. And if we look at the United States, you'll see these are data from the CDC up to April 9th. And you'll see what happens is when you get a more transmissible subvariant now, like BA.2 in this light pink, what happens is it overtakes the prior dominant variant. So you'll see here in the light pink is that BA.2 essentially becomes the dominant variant identified in all the viruses that samples that are being sequenced. And at that point in time, the CDC estimated that about 86% of all the sequence variants in the United States belong to Omicron BA.2 variant. If you look at region 2, where New York State is situated, you'll see that we're at about 93%. So clearly it's the dominant variant in this region. And obviously these data tell us immediately that this is more transmissible because it just has been able to overtake the previously circulating variants in the community. So how does BA.2 compare to BA.1, the original Omicron? And these are data from the UK, but they're very informative. Of course, it's taken over as well in the UK, up to 83% of the sequence of the cases that have been sequenced. It's about 80% greater relative growth compared to BA.1. Importantly, in terms of secondary attack rates, meaning transmissibility within households and non-household settings, it does appear that when you compare BA.2 to BA.1, again, more transmissible, like 13%, it's 14% or so of household contacts infected versus 11% amongst the original Omicron variant. And amongst non-household settings, close contacts, 5% versus 4%. Another important aspect is hospitalizations. I think the evidence we have now, more and more evidence, is there's no evidence of a greater risk of hospitalizations following BA.2 compared to BA.1. And when we think about reinfections, there's a small number of BA.2 reinfections that have been identified following a BA.1, the original Omicron infection. Do our vaccines work against BA.2? And remember, that's the third question I had in my list. And this is where we have good news. And you'll see here that in these 2 dots here, this is BA.1, this is BA.2. And you'll see when you look at people who've received 2 doses of the vaccine, and this is the time since vaccination. We know there's waning after vaccination, but they seem to track together very nicely. And then this is after receiving a booster, and that's why we strongly recommend that people get a booster. You can see the protective effect, the vaccine effectiveness noted, and again, BA.1 and BA.2, they track together very nicely. And this is also data demonstrating that's very similar effectiveness of the vaccine. This is looking at the vaccine, that a similar effectiveness in protection against hospitalization also between BA.1 and BA.2 variant. Let's move on then to why is it important? What are the data regarding the second booster? There's been a new study that I think has largely informed the recommendation for a second booster for certain populations. And this is a study of effectiveness of a 4th dose. The study was done in Israel. and looked at the outcome in people who received the fourth dose of the Pfizer vaccine with those who had not. And what they found is, based on these figures here in the blue, is the control group. These are people who got did not get the fourth dose. And then in the orange are those who got the fourth dose of the vaccine. And you'll see that, again, when they looked at their vaccine effectiveness, they found that it was substantially the booster dose. Those who received the fourth dose had substantial protection against infection, 50% reduction, 61% protection against symptomatic illness, 72% against hospitalization, 64% against severe illness, and 76% decrease in risk of death. These data are very compelling because it's not looking at antibodies in the test tube. It is looking at really clinically meaningful outcomes. And that's the reason why this fourth dose has been now recommended for specific subsets of the population. So who is the second booster dose authorized for? It's authorized for people who are aged 50 years or over, anybody 50 years or over, and immune-compromised individuals aged 12 years and over. They can receive the second booster 4 months after receiving their first booster dose. Remember that, 4 months after the first booster. Those who had an initial vaccine that was Johnson & Johnson Janssen vaccine should get boosted with an mRNA vaccine. And those under the age of 18 who are immunocompromised should be boosted again with the Pfizer vaccine, which is authorized for that population. I'm going to move on and touch on another topic, which is long COVID. We have learned a lot about long COVID and continue to learn every day, and there are lots of ongoing studies trying to answer a lot of questions about this very serious complication associated with SARS-CoV-2 infection. What we've learned is that there are some predictors. Studies have looked at and identified predictors of long COVID, meaning who is more likely to develop long COVID, or what's called PAX. And what's been noted in several studies is people are much more likely to develop long COVID if they've had severe COVID-related illness, if they had higher levels of the virus in their bloodstream, and then presence of other risk factors like autoantibodies. They do have diabetes type 2 or demonstration of this other virus in the bloodstream. And this shows you here on this side, it's a complicated figure, but I think what it shows clearly, as you can see, the risk of COVID is increased when you're hospitalized in orange or when you're in an intensive care unit in purple. So we now have evidence that severity of illness of COVID-19 means more likely to develop long COVID. And fortunately, we have ways to prevent severe illness, and that's really good news. So we have now data that actually suggests that vaccines decrease the risk of long COVID. And you can imagine that because vaccine decrease the risk of severe illness and hospitalizations, that's the reason why various studies, several studies have shown that people who are vaccinated have a 40% decrease of risk of long COVID symptoms compared to unvaccinated individuals. So this is very good news. It's another benefit of getting vaccinated and boosted is preventing severe illness and therefore decreasing the risk of long COVID. And this is another study that has also shown the same thing, is that when you compare vaccinated individuals with those who are unvaccinated, you see that that there's a substantial protection from developing long COVID amongst those individuals who received vaccination. So you'll see here that these are in this purple, purple color here, this bar here, these are amongst people who are vaccinated 2 doses. And you can compare that to the risk of long COVID amongst those who are vaccinated just 1 dose or those who are unvaccinated. So you can see that in terms of all of the symptoms that have been commonly reported with long COVID. So the good news is that we have now evidence from several studies that those who received 2 doses, and hopefully those again who got boosted, they're less likely to than unvaccinated individuals to report symptoms of long COVID. I want to touch on COVID treatment because that's the other game changer. We always talk about availability of vaccines, but I think treatments, effective, available COVID-19 treatments are another game changer. Where are we at now? And we're very fortunate in the United States to have several options for treatment as of now. And two of these are antiviral drugs. They're given orally by mouth. They need to be taken rapidly after development of symptoms or after testing positive among certain individuals who are at risk of complications from COVID-19. The two drugs are molnupiravir, and this one is Paxlovid. There are two other monoclonal antibodies that are also, again, have been shown to work against the Omicron variant. Some of the older other monoclonal antibodies are not effective against BA2, so that's important to keep in mind. What about these two drugs, the Paxlovid and molnupiravir? They're both antivirus. They act on the virus. You can see the number of pills that need to be taken every day for 5 days. And what you notice is that the evidence suggests that Paxlovid is more effective, about 90% protective against hospitalizations, which is very, very important. And importantly, these treatments must be started early amongst people who are eligible for receiving such treatment. And these are people who have underlying conditions or older individuals. So they should be initiated on treatment as soon as possible and continue to take these oral treatments to prevent complications and hospitalization. So I mentioned there were two monoclonal antibodies that work. One is authorized for the treatment of mild to moderate COVID-19, very important. It works well against BA1, BA2, BA3, and decreases the rates of hospitalizations and death. And there's also another monoclonal as well that has been used for prevention as a pre-exposure prophylaxis for prevention of COVID-19 in certain individuals. And this is also very important to keep in mind, particularly for populations who are less likely to respond well to vaccines in severely immune suppressed individuals, for example. There are many ways to get these treatments. Through obviously people who are diagnosed and believe that they are eligible, they should call their provider. But also if you go to this website, covid.gov, you will find an abundance of information on this website. You can put in your zip code and you'll be guided to treatments within your community. In New York City, if you call 212 COVID-19 and then press 9, you will be connected directly to a clinician who will have a conversation with you, assess your risk, prescribe treatment for you, and the treatment will be delivered to your home. Another question we got is, what about moving from pandemic to endemic state? This is a complicated question, and there's no really definitive answer to that question. There are a lot of differences between what we call an epidemic, which is when you see an unexpected increase in the numbers of cases in a location. Pandemic is very large increase, exponential growth in numbers of cases, affects several countries and populations. Of course, we think immediately of the Black Plague in the 1300s, Spanish flu, swine flu, and HIV/AIDS, which continues to be a pandemic. And then endemic is a consistent case count in a consistent region. So there's a kind of a predictable pattern. That's when we call something endemic. Examples of this are malaria in certain countries, as well as sickle cell anemia, sickle cell disease in some countries as well. So keep an eye on the words predictable pattern. So the World Health Organization has this figure that shows the different pandemic phases. And I think we have been in this pandemic phase, which is widespread human infection. And then there's a post-peak, which is possibility of recurrent events. And that's kind of the phase we're in now, possibility of these recurrent events with new variants and so on. And ultimately moving to endemic state or post-pandemic state is where disease activity is at seasonal level, meaning it's predictable, that we can actually predict when we're going to have another cycle of cases. So examples of some endemic conditions are influenza, and I encourage people to think of influenza as a very good example for maybe what we can hope for or think will happen with COVID-19 over the next several months and years. We know that the COVID-19 will be impossible at this point to imagine that it will be eradicated or eliminated, but we may transition well into a situation similar to the flu and have it become endemic. And luckily, we do have vaccines against COVID-19, and also we have treatments as well, which is very similar to the situation with influenza. We have vaccines and we have treatments for influenza. So I want to end by summarizing quickly that COVID-19 cases are rising again in New York City. However, the case numbers and case rates are unreliable. Keep that in mind. Hospitalization rates are more reliable and they remain stable, but I anticipate they may rise as well. Increase in cases likely due to a lot of different factors, the BA.2 variant, low booster coverage, 37% only in the city, and lifting of some restrictions. Fortunately, BA.2 does not appear to cause more severe disease or evade our vaccine-induced protection, particularly with boosting, or also we have certainly treatments that are effective. And long COVID is associated with most severe illness, and now we have evidence that vaccination can decrease its risk. And then the transition from pandemic to endemic state can take various forms, and it remains really to be seen how we evolve into an endemic state with SARS-CoV-2. Thank you, and I'll stop sharing.
Great, thank you, Wafaa, so much. A lot of Wafaa's presentation and the things that I'm going to talk about address the pre-questions that we got. There are a number that we're getting, and right before I start, and I'm going to kind of breeze through what I have so that we can get to all the questions. There was a question Wafaa put into the Q&A about the number you used on the percentage of COVID cases in the hospital. And the question was, were they people who were admitted for COVID, or are they people who have gone in for something else and tested positive, or some combination of the two?
Yeah, I mean, I always say admitted for COVID, admitted with COVID. I mean, the different, and this is, it's both. It's very hard to disaggregate those, and that's the reason why we always say that probably some of the hospitalized individuals that are lumped into this COVID hospitalization, maybe people admitted for something completely different, and they just are all getting tested, and some of them test positive. So it's both.
Great, thank you. And the number that we use here at CYMC and across NYP is it's roughly 50-50 in terms of that split. Okay, so I'm going to start. I want to touch on sort of where we are at the university, a number of the questions we got on masking, on the move to a mask in the classroom policy, update on the booster mandate and our travel policy. And we also have gotten some questions about commencement and our visitor policy. So a lot to cover, some of which you have gotten information about, some of which you will in fact get information about tomorrow. So we're going to give you a little bit of a sneak preview on where we are in the booster mandate. You can go to the next slide. So as you know, we publish weekly our testing results that we do in the 2 campuses for asymptomatic individuals. And we also publish our random surveillance testing. And we also, as Wafaa indicated, encourage people who are doing outside tests, either at a location outside of our 2 testing facilities, or they're doing it on their own, to report into COVID Test Trace. And so you can see our positivity rate number is 4.4%. That's higher than it's been for quite a while. Not as high by any means near the time when we had the Omicron surge, but it is higher than what we've seen in most of February and March. And so that also informed us in making taking the step that we did on masking in the classrooms. You can go to the next slide. And then this chart just shows you how it has looked over time. So as I said, very flat across most of the second part of 2021, with that huge spike in that looked a lot like the spike Wafaa showed you, which was a citywide number. This is our Columbia number, but again, with a huge drop once we got into the middle of January. And you can see that the lines for students in particular exceed the faculty and staff number, and but still, roughly over time below the 2% number. We did not plot, by the way, last week on this just because of mechanics, but you can go to the next slide. So reminders about our testing program. So we still do have our testing program. I know one of the questions was, why aren't we reinstating it? And the decision, reinstating the voluntary testing part of the program, the decision was based on the broad availability of testing, not just across the city, but self-testing, which you can do in 2 forms. One is the federal government has provided us with the opportunity to get tests sent to our home. And in addition, our insurance at Columbia provides for reimbursement of those of those tests that you might procure in a drugstore. We're giving you information which hopefully you've utilized how to arrange an appointment. We are continuing to do both gateway and surveillance testing for our affiliates and also our wastewater testing. So we're able to detect if something's beginning to happen that is of concern across our affiliates. You can go to the next slide. This is the instructions, and again, these will all be posted. I'm going to go through them quickly, but it's posted on the COVID-19 website subsequent to this briefing. But as I mentioned, you are eligible to receive free at-home COVID tests. I'm often asked by people, as I'm sure Wafaa is, once I get COVID, should I keep testing myself? The answer is actually you should not. There's no need to just do continuous testing. And again, of course, you want to watch for symptoms. In addition, as I said, if you're in the university's employee medical plans, you get reimbursement through United Healthcare or OptumRx, who is our pharmacy benefits manager. And you can get 8 tests a month for COVID, should you choose to do that. You can go to the next slide. One of the things that we wanted to also help you with, and hopefully you've seen this before, is what do you do when you take a self-test? How do you use it? And then how do you interpret the results? And so we provide you with instructions about, when you do a self-test and you are symptomatic, the recommendation, of course, is that you isolate for 5 days after the symptoms are dominant. And after 5 days, if you still have symptoms, we recommend that you actually will continue your isolation period. If you're asymptomatic and test, there's just some simple precautions that you should take, notifying your close contacts and wearing a mask as you go forward. You can go to the next slide. As I said, there's a lot of other ways to get tested in addition to that 8 free tests that you get from our employee benefits plan. Or if you're not covered by that plan, the availability through the government. You can go to pharmacies, the testing sites, although they're not as many as there were certainly in the peak of Omicron. They are often on subway locations. They're in Grand Central. They're in multiple places where you can get tests. You can go to the next slide. So I want to cover briefly masking and the rationale behind our decision to reinstate a classroom masking requirement. And hopefully you've both seen the information, and outside of classrooms, we've developed some signs that are fairly prominent. So we thought, given that uptick in testing and the fact that we're ending the semester and going into exams, and that students are also going to begin to be traveling home, that it was a good precaution to return to a masking policy just in the classroom. So you do not need to wear masks outside. You do not need to wear masks at social gatherings. And you do not need to wear masks at a library or dining hall. At the same time, many people do. And in fact, the other side of this is that in healthcare locations like CYMC, Columbia Health, our various testing facilities, we do require that masks are worn. And of course, as you've seen, there are mask requirements in public transportation locations, including our subways, in airports, and recently the airlines decided to extend their requirement for passengers on flights to mask. So masking is really the only requirement. I'll talk about boosters and vaccines in a minute, but we don't require social distancing. We don't require any, there are no restrictions in our gathering policy. You can go to the next slide. So we have visitors, as you well know, to the campus, and I'll talk about the biggest event of visitors, which is going to be commencement coming up in about a month, and what the protocols are there. So the visitors have to comply with our masking protocol. So if you have a visiting faculty member in a classroom or a visiting student, they must be masked. If you have a visitor who comes in for other purposes, the requirement for them is they do not need to be masked, but they do need to have proof of vaccination. That's collected at the department level or wherever they have been invited. And they do not at this point need a booster. We're obviously strongly recommending boosters. And as I said, I'll get into that next. They also don't need to do daily attestations. None of us need to do that anymore in any event. Of course, we urge caution should you be having any symptoms, and it's advisable to stay home when you have symptoms, whether they end up being COVID or something else. You can go to the next slide. All right, so commencement. We're all very excited to have an in-person commencement, and we know there's multiple classes that will be returning for commencement, not just the class of 2022. So all persons over the age of 5 must meet the fully vaccinated status condition, which right now is, 2 shots of Moderna or Pfizer or 1 shot of J&J. And we are asking for proof of vaccination. As you well know, we have some people here who are Columbia affiliates who have gotten medical religious exemptions. And we are asking them to provide proof of a negative COVID-19 test within 72 hours of graduation. And if you are over the age of 2 and you can't get vaccinated, for example, you're between 2 and 5, we are asking you to wear a face mask. There is a website for commencement that has all of this information in detail. And as I mentioned, boosters right now are not required for anyone at commencement. You can go to the next slide. All right, so the important update we have is on boosters. As I said, you'll get information about this tomorrow. We have made a decision, as you recall, the first decision on boosters, which we strongly recommend that you get, was that as of February 21st, partly because of some state requirements, healthcare workers were required to have boosters. We aligned that with general university policy, deferred the enforcement of that until late May. We are announcing tomorrow a decision that for faculty and staff, we will re-examine this over the summer. Again, we strongly encourage you to get a booster, and as circumstances change, whether it's about a second booster or maybe a third booster, or boosters that are specific to the strain of the virus that are present, we'll continue to update and modify our policies. But we have made a decision because our registration for the fall semester of 2022 is upon us. And so we will be requiring a booster for all undergraduate and graduate students for registration going through the fall. We will reopen and expand our booster offerings in the 2 student health locations. And of course, you can always go to multiple sites that are outside of the university to get a booster shot, or go on to vaccinetogethernyc.org to schedule an appointment. You can go to the next slide. This just as a reminder, the way that once you get your booster, that you upload the information is through your Reopen CU app. Tomorrow you will be able to see and confirm whether or not you have uploaded that booster information. We encourage you to do that, faculty and staff, even if it's not a requirement today. We encourage you to upload that information. It's a place where you, establish proof that you have gotten that. You can go to the next slide. And then the last thing I want to touch on is our travel policy. We have made some changes in our travel policy. For the most part, it is not a significant change from the spring. The key part is that we want to keep registering travel. And as you've seen, international incidents all over the world not related to COVID, it's important for us to know where our affiliates are to determine whether they are safe or not, to provide assistance to them should they need to return to the United States. And our approval process in the past, which required sign off at a variety of levels has also been modified. And I think that's it for me. Can you go to the next? Oh, just to give you the link on all of the policy changes. And again, we continue to update them. We will have a webinar on all of the travel requirements as people contemplate summer travel and fall semester abroad and the like. We have a webinar scheduled for April 27th, and you'll be able to register for all of and find out all of that information. And I think that's it for me. Correct? Great. So we're going to go to some questions. And Wafaa, why don't I start with you? We have a number of health-related questions. One of them is, can people get Omicron more than once?
I showed that on one side. There are some data. It seems quite rare. That's all I can tell you. But I think we need to wait and learn more as we keep moving ahead. But based on some of the UK studies, it's rare, meaning handfuls of cases where this has been documented.
Great. Could you talk a little bit about, there is a discussion about a new variant, what that looks like, and should we be worried about recent reports that it's more transmissible than even the BA2 variant?
Yeah, and I always tell myself whenever I can tell you that every day there are new variants, and all my teams that are based all over the world, they send me emails about this variant was identified here and there and so on. And I think you have to wait and be able to answer those 4 questions that I listed in one of the slides. And we usually learn pretty soon if it's substantially more transmissible, because it's just to look at the pattern over time if it takes over the prior variant. And then we have to wait for the data. There could be laboratory data in terms of how effective the vaccines are. It could be in terms of the treatment effectiveness. It also requires clinical data that should be collected over time to see does it cause more severe illness or not. So I think it's hard to tell when you're just hearing of the early news. We have to wait for more data to be able to answer that question.
Great. You know,
I think the other thing is just to keep in mind is that since all of these are sublineages of Omicron, of one kind of a strain Omicron, the hope is that our vaccines and our treatments will continue to be effective because they appear to be kind of another brother or sister of the Omicron variant. But that is not 100% sure, but nonetheless, at least, it's likely that because they are emanating from the same strain that they would have a similar pattern, but it's too early to tell.
Great, thank you. We have a few questions about the second booster. The first one is, should you get a booster? Let's presume that you got a booster in the late summer or fall, which when many people are eligible. Should you be getting a booster now? Should you wait? What's your advice?
I think now for people who are contemplating a second booster, it depends who you are. And I think, again, I feel like if people who are eligible, particularly based on the data I showed from Israel, which was amongst the 65 years or older, that did show benefit in protection against death. It seems that that's a very compelling finding. But I would say that for such individuals and those with comorbidities and who are older than 65 years of age, I think it's a good idea to get a booster, the second booster dose, so long as it's 4 months since you've received your prior booster.
So one of the implicit questions in that, and someone asked a variation of this, is though, if the only thing that's being authorized is a second booster, and it's summertime and maybe the infection rates stay low, or should you wait to get a booster until the fall, given that will keep you current as we go into potentially another winter season where people are more indoors?
Very tough question, and we don't have yet a sense, and that was the last part of my presentation. The predictability factor is a big unknown as of yet. And we know that it's not unusual to have a sudden appearance of a new variant almost overnight, like Omicron appeared almost overnight and then took over very rapidly and quickly. So it's hard to anticipate. I think we're hoping that over time, we will move into more of a predictable pattern like with influenza. So we can then develop a vaccine every year for the new circulating flu virus, and then everybody can get it in the fall and be protected over the winter, the fall and the winter. We are not there yet. And that's the reason we are essentially being driven often by data that are emanating from different parts of the world. And sometimes the data are not perfect, but that's why, I try to look at, are the data compelling enough to justify the need for a booster? And I felt that in looking at the data that I mentioned, that because it was looking at clinical findings, I think the data were quite compelling to get it now if you're eligible.
Great. A related question is, if I recently had COVID, should I wait for a while to get my second booster, not my first booster, but my second booster?
Another unknown question. I think usually what we've told people is that they're eligible, they should wait till they recover, they're symptom-free after they've had COVID, and then schedule their booster dose at that point in time if they are eligible. And that remains the recommendation now, standing recommendation.
Right. Wafaa, you also talk, I'm sorry to give you all these questions, but
my pleasure.
They all sort of fall in your bucket. There is another question about the booster and long COVID. And so have you seen any data about long COVID for those people who have gotten a second booster, which would be a small subset of people?
Yeah, I mean, we don't have the data, but remember the whole idea of how vaccines could protect against or decrease the risk of long COVID is because they decrease the risk of severe illness. So anything you can do to decrease your risk of severe illness, whether it be through getting boosted or whether it be starting treatment right away if you're eligible for treatment to decrease the risk of severe illness, that hopefully means you'll be less likely to get long COVID. So I think anything you can do to decrease your risk of severe illness, this has a strong likelihood of decreasing risk of long COVID, whether it be vaccination or rapid treatment.
Right. I'm actually going to turn to Gerry, and I'll give him an assist and then see how the two of us do. And the question is, why are we not enforcing the booster policy when Dr. El-Sadr keeps reiterating how important it is? I do want to bring to your attention that about 85%, and it could be more, of our Columbia affiliates, faculty, staff, and students have in fact already uploaded their booster information. It's likely that a significant number, more than that, have gotten a booster but just haven't uploaded it. I think part of our thinking is, what are the consequences for failure to get the booster? And we want to be mindful of the fact that there have been some, questions around exemptions for boosters, that maybe people got the first and second dose. But more importantly, we want to watch what's going on in the status of the coronavirus around the world, and certainly the US and New York. We also would be quite unusual in enforcing the booster. In fact, you've seen a lot of changes nationally, but certainly even locally, where various groups of individuals have even been allowed to not get vaccinated. But I'll turn it to Gerry to share what his thinking is around why we've decided to wait until the summer to enforce, to make a decision about enforcement of the booster policy for faculty and staff.
So Donna, I don't have much to add to what you said. One point that you didn't mention, but I think is important to emphasize, is that we had advice from the public health expert group that we have at the university. So this wasn't a group of administrators sitting around and making this decision. We listened to what the public health experts said and were guided by that. On the question, I saw the question in the Q&A, and I'm glad you made the point about where our compliance level already is, because Wafaa showed numbers for the city of New York that I think were in the 30s in percentage, and we're 50 percentage points higher than that in terms of compliance. So no one should infer from the lack of enforcement that we have doubts about the effectiveness of the booster, the importance of getting the booster shot. We reached the point, I would say, I'm just repeating, Donna, what you said, we reached the point where we were down to a small number of people, some of whom really didn't want to get the booster shot. And there was a lot of friction around that. And the climate overall, other institutions, what was happening to healthcare workers was that everyone started backing away from the extreme penalties for not complying with the booster mandate. And that's what caused us not to withdraw the mandate, but to say that we are deferring enforcement. And as you pointed out, deferred that, we said, through the end of May. Now we're indicating that we're not going to revisit this until some point in the summer. We're going to take another look at this enforcement question.
Great. Thank you, Gerry. Wafaa, there's a question, and of course, we've all been through multiple waves. And so as you pointed out, this spike in cases internationally is occurring in the Western Pacific area and in Europe. Does that suggest that we're going to see another spike, certainly of greater magnitude? I wouldn't call what we've seen so far a spike, but what's your prediction about whether this is going to catch on again here in the United States and more importantly in New York?
Yeah, it's interesting. I think the several European countries are really experiencing the surge from the increase from the BA2 subvariant, which we are sort of seeing the uptick. I call it an uptick, or in terms of numbers of cases. So I think we usually lag a bit behind European countries, and I think we are lagging behind again, as predictably, a few weeks. It's anticipated that probably we may peak in New York in about a week or two. Now, in terms of countries in the Western Pacific, I think that the situation is quite different. When you think about China, I mean, there's been a lot of attention paid to Shanghai, for example, and what's happening in Shanghai and other parts of China. As you will recall, China had a zero tolerance, essentially, policy for COVID, meaning that their population is, and they've also had vaccination uptake, but not as good a coverage as New York City, for example. And in Hong Kong, as one example, the older populations was not vaccinated, at least high coverage with vaccination. So you have a naive population that has not had COVID in the past because they've been so protected from getting COVID, so they have not had prior infection, and they have also gaps in vaccination. So they're very different from the situation in a city like New York City, where we've had a pretty high attack rate, including with the recent Omicron. And in addition, we have high uptake of vaccines, of vaccination. So I think we are in a very different, we're in a very different status in terms of the community and our experience with COVID and our protection against new infections with COVID.
Right. We have a couple of testing questions. First of all, thanks to the person who put into the chat that she, in fact, ordered her tests from the Optum RX store, got them right away, and highly recommends it to everyone else. But we have another person who got the tests and they had an expiration date. The question is, are the tests still as valid 3 months after the expiration date, or do they lose their validity after a point in time?
So a very good question. I think the companies that make these vaccines continue after they actually are marketing the tests. They continue to do tests on the assays on their tests. And then they submit the data to the FDA. FDA looks at the evidence that they've submitted and then allows them, based on the evidence they've submitted, to extend the expiration date. So this is based on indications from it's not the company that makes that decision, it's the FDA that provides the company with the authorization to extend the expiration date. So yes, I would say if that's what it says for the testing kit you received, then it is 3 months beyond the expiration date.
Right. There's a question about contact tracing in classrooms, and I'll attempt to answer it, and Wafaa, please jump in. And as we've reported across these webinars over the last 2 years, there really has been very little evidence of classroom transmission. And that most of the transmission was back in social settings. You know, you went to dinner with somebody or maybe even a family member. We have not seen that evidence now. What we have seen some very small clusters in athletics, but not in classrooms. So our feeling, even though we return to the mandatory masking in the classrooms is that classroom transmission is extremely rare and the campus continues to be very safe. But Wafaa, did I miss anything in that?
No, and I think in the note that went out, it did highlight the fact that people should be particularly cautious in contexts where we know the risk is substantially higher, where you're in public settings and crowded public settings, indoor, and also where you don't know the vaccination status around you. And we're very fortunate at Columbia to be highly vaccinated and highly boosted the community. Both of these are should allay anxiety that some people may have about the safety of the campus.
Right. There was a question in the chat also about Barnard, and I guess I want to just also maybe extend it beyond Barnard. One of the things that a number of members of the task force and the public health group do is they keep in touch with what we call our Ivy Plus peers. So it's the Ivy League schools, but it also includes the University of Chicago, Stanford, others. And we get lots of information from those schools. We watch the trends, but of course, some of them are very different. They're different settings, rural versus urban and the like. So that we do look at what all the other schools are doing, whether it's respect to testing, to vaccinations, to gatherings. And Barnard, of course, just given its proximity and its relation to Columbia, we're very closely aligned with Barnard. There still may be a policy or two that aren't completely in congruence, but we do work very closely with Barnard and their vice president for wellness. I'm going to, Buff, I think I've got maybe a minute or two before I ask Gerry to wrap it up. We do have one question about, does the virus linger in places? In this particular question, it is an infected person was in an elevator and left. The remaining people or a new person that comes in, is there a concern about the virus being in that space?
Yeah, there's always concern, and it depends on the ventilation status of the space. I mean, I think that's ultimately makes a huge difference, and that's why the university has put so much effort into upgrading ventilation and filters and so on, because it really is dependent on the ventilation of the space itself. And also it depends on the duration of contact. We know that there's association of increased risk when there's longer contact. So it depends how long the individual remained in that space where somebody else was infected. So there are lots of variables and we don't know precisely how long the virus may linger in the air. We know that it's probably hours after it's been disseminated, but this varies substantially based on how the air is circulating in that space, in that elevator or any other space.
And it's one argument that says, if you're concerned, wear a face covering as often as you can.
And especially if you don't know the status of the individuals who are around you in such a space.
And I'm sorry, there are just a few questions we didn't get to, but we'll take a look at them and make sure that our FAQs on the COVID-19 website reflect them. But let me turn it back to Gerry.
So just to take a minute in conclusion, just what an amazing presentation by both of you. And many of you have been at all of these webinars, or a lot of them. You don't need me to say this, but I just want to be on the record with this in case this is the last time we're together with a webinar. We've been at this for more than 2 years. Donna, you've been our university COVID director throughout this period with more than a full-time day job, and you've just done an extraordinary job. Wafaa, the same for you. You're managing so many things and have led our public health group effort all along. Melanie, not here today, but the same is true for her. So we're all so in your debt, and I hope you know that. But thanks for another really great session today.
Thanks, everybody.
Thank you, everyone. Have a good evening.